I'm Kelly John, podiatrist with Ortho Illinois. Thanks for inviting me tonight. Tricia Stewart is my MA. So she's been with me through this whole process of moving to this new system of bunion correction. So bunions and hammer toes are probably my bread and butter. Do a lot of it. I love that we have this over here that says get to the bottom of your pain and it's your feet, right? I mean, that's where it starts. So what's new in bunion surgery? This is a 3D bunion correction called the Lapiplasty. That's a trademark name. It is all over. If you're on Facebook, it'll come up. If you Google bunion, it comes up. The Treese company really went after the consumer rather than trying to go after the doctors. It's hard to get a doctor to switch. I honestly did like the whole setup where they did a lab for us. I'm like, yeah, whatever, it's the same as old. And then the patient came to me with it on her phone and said, can you do this? And I'm like, yeah, kind of with different instruments. And she's, I'll think about it. And then one of my residents said, hey, can we do that again? They want to come out again. About the second time I did it, and a few little steps along the way, I was more convinced on why this was truly a different way of doing a bunion surgery. So Lapidus is a person, an American person from 1934. I believe he's American, at least English speaking, because it was the first English speaking literature in where he said, we shouldn't be correcting the bunion up where the bump is. We should be coming back to where the deformity is, which is first metatarsal cuneiform, tarsal metatarsal joint. And he cited this other guy, which was in Russian, but that poor guy doesn't get his name on the procedure. So we all call it a Lapidus procedure if we're doing that. And it's been around this long. So what is the bunion? So you guys see all of these, right? So we think of the bump, but it's really the mechanical alignment. So the first metatarsal is moving over medially, the hallux is moving lateral till you end up with this. Not always, not everybody from mild goes to this, but they can. If mom and dad had this, more likely. So what does cause it? I really feel it's genetics. You start with a really flexible foot, a weak medial collateral ligament. It can move over. Hyperpronation, definitely. Hypermobile. In fact, people who aren't hypermobile will more often develop arthritis. This is not a procedure for big toe joint arthritis. In fact, it's contraindicated there. So if I have someone who's really arthritic at that big toe, it's not going to reduce its deformity. So shoes, people often say, do my shoes do it? There are native people in parts of the world that don't wear shoes and they still have bunions. This is my true feeling on it. The shoes make the symptoms worse, right? Women's shoes, to be at all within a social norm, are more narrow. Men will just buy a bigger shoe until they're wearing a 16 and they just don't care. They don't care how big their shoe is. Women tend to feel out of the norm unless they're wearing a more narrow shoe. So, of course, then our feet hurt more. So, non-surgical treatments. There's lots of bunion splints. In fact, another physician in town came with something like this. And again, he wore that inside his shoe. So if you could, 24/7, dial your foot back into the right position, maybe. But a little bit of yoga toes or a toe spacer for a couple hours isn't really going to change that mechanics. So is there room for improvement with splinting, orthotics, physical therapy? Probably some symptom relief. But remember here, this adductor tendon comes right up here, and the flexor tendons. So once this moves here, the flexor tendons are no longer in line with the first metatarsal and the big toe. So the more it pulls that toe lateral. And so you guys are working like crazy to go the other way, and every step it goes the other way. Maybe early on you could do some physical therapy with an orthotic and reduce the progression of it. So on x-ray, what do I look for? Is one parallel to two? That's where I start. Is one parallel to two? No. Sesamoids usually really kind of stay put, and the metatarsal head shifts off. And we used to just say shifts medially. But one more thing I want you to look at that Lapiplasty really, really looked at. It's moving in the frontal plane. So this metatarsal is rolled, and that big toe is rolled. So think about your pronator. They're going to come here, supinate, neutral, pronate, and they're going to roll off. And they're just going to keep wearing this out. Bunion gets bigger and bigger. So a normal foot versus a bunion angle. I used to go crazy on measuring these angles, and if you were between 10 and 13, you did a head procedure. In the middle, you did, if it's a bunion, it's bunion. And I fix them all pretty much the same way with Lapiplasty. So we used to say 7, 8 was normal, 10 up here. This is 37, that one's 19. Again, one's not parallel to 2. Sesamoids are out, and these are rolled. So this is what chevron, old school bunion, was. I cut the head and moved it over. And I don't know if you can see these angles, but we measured these before and after. So we measured this, and it was 13.1. We measured this, and it was 4.3. Off of where the head is, but not where the base is. The base would be exactly the same as it was. So, and then if you look even closer, that's pinching right there. Right? So now you guys are going to try like crazy. Oh, you're a little stiff, the therapist will take care of that. No, you can't. It's going to jam. And you're going to be mad because you're going to be trying to move this toe and it won't go up because it's hitting into the metatarsal. Another one I did was called scarf. And this was I know the measuring, what we're trying to do there. We're trying to keep the metatarsal from shortening. That was a really important thing when you're making all those bone cuts. If you make metatarsal 1 too long, they actually hit the ground with their second metatarsal. Second metatarsal, as you all know, isn't made to push off, right? So then they end up with this second toe pain. That gets weaker. What happens? It starts to contract up and you get a hammer toe. The bunion now is pushing that elevated second toe, goes underneath it. They just, hammer toe, bunion go right together. So I know in this one we were trying to maintain the length, but cut that. Again, the head's not too bad. The sesamoids look pretty good. I even cut and angled the toe over a little bit. But if we go down here, the real metatarsal base and the second are not parallel. That's what a scarf looks like from the side. So you make this Z, you slide the top over the bottom and put those 2 screws in. So it's more correction than that first one I showed you with just a chevron. Scarf is actually I believe, a woodworking term. It's kind of a tongue and groove that woodworkers would use. So the traditional bunion relied really heavy on the soft tissue. I released the lateral side between the first and second toes, and I really tightened that medial capsule. And then again, I send them to you guys and say, make this move again. Well, I just cranked it tight in the OR. On the table, it looks straight. It is straight. But over time, they stretch out. Then the bump comes back. And the toe actually still remains rotated in that frontal plane. The toe and the metatarsal. So that third plane is that frontal plane. So the transverse plane, moving medial to lateral, bump, right? Or move the bump over. Sagittal plane is don't make it too far down or make it too far up. Make it same line as the parabola of the metatarsals, kind of even weight distribution. And then the third is this frontal plane. And so we look where the sesamoid position is and the metatarsal base. So this is a different picture that we usually didn't get, called sesamoid axial. On an X-ray, you can see those sesamoids are no longer to the ground. You're actually kind of walking off the medial one. This is a weight-bearing CT. This is one that they tried to show in the Lapiplasty literature. This is this with the sesamoids here. They're almost not even to the ground. You're walking off the head. After they did the Lapiplasty, they're back underneath, kind of moving the head over the top of the sesamoids. The flare, this is where it really, it was like the light bulb moment. I'd heard about the Lapiplasty. One of the founding people for Lapiplasty is Paul Dayton. He was giving a lecture in Chicago at a conference. And he said, you know that flare, the bottom of the first metatarsal? When you do that Lapidus procedure, if you don't cut that off, you never can move it over. You're trying to move one over to two, and you're cutting that off. So you know what that flare is? So it's actually the bottom of the metatarsal. So I brought this because I thought maybe it would be easier to explain. If the bottom of the metatarsal is pointed and you roll it, you will see here that flare. So if you roll this back, that goes down, and this bump actually comes dorsal. And so, of course, I didn't believe them. First Lapiplasty I did said that bump's got to go. Just like my old school one, I went in there and shaved that bump first. Then I put their positioner on and went, oh, maybe I took too much, because it almost disappears when you put it back where it belongs. Granted, there are some people who've had it for so long, they have a bony buildup over here, and I do shave those. So this one I chose because of the nail polish. So it makes a really good picture of where the big toe is. The nail is facing off, right? And so I'll be in the office, I'm pushing their metatarsal head in and rolling their toe and saying, see, your big toe is facing the wrong direction. If you shave this bump off, that toe is still pronating, really. Also, I noticed on this picture, it's a little red right here. I feel like you see this more with a hypermobile foot. And you know, I have this myself, not a bunion, but a hypermobile foot. I have a big bump right here. When my first met cuneiform is moving way too much. So I've developed spur, I've developed soft tissue hypertrophy. So I start to look for this, if there's a bump there. So why wasn't it done then? Paul Lapidus said in 1934, why aren't you doing this? This is the best way. It's really technically difficult to achieve all of that in the operating room, in all three planes, when the patient is asleep and not weight bearing. For many years, we didn't even have a portable x-ray. You did it, and then they left the operating room and then took x-rays. So you couldn't even really see where you're throwing screw, where you're making bone cuts. Fusion, 6 weeks non-weight bearing. That's a long time for most people. And so we would cheat it, do that head procedure, and walk them much earlier. And then you lose the joint. You're taking out a joint to realign it. You're fusing it. You're fusing it at the metatarsal cuneiform, not at the MTP joint. So there were hardware limitations. For a long time, we didn't have anatomical plates. We took a 1/3 tubular. Everybody got a 1/3 tubular, whether you broke your arm, wrist, leg, stuck that 1/3 tubular on, and that's what you had. And we didn't really understand the mechanics. I can't say we know them 100%. 26 bones, I don't know how many joints. You know, how do we really know with every person in every phase of gait exactly where their foot's going to end up? Every step, 10,000 steps a day, are changing that position. So somebody else, I can't remember who said this, but there's two theories. The osteotomy versus the arthrodesiocrats. Two parties, right? The people who are in favor of the Lapiplasty would say, why would you take a perfectly straight bone and make it into a crooked bone? Why would you do that? But then on the other team, they're saying, why are you taking a perfectly normal joint and removing it, and fusing it there? We feel that the joint is not normal. It's unstable. It's not necessarily arthritic. It's just unstable. So we had to stabilize that joint. So this is a head procedure, but this thing is still way over there. And a lot of their literature would, Lapiplasty literature will show that. The width of the foot after this didn't change. They still have a wide foot. They want to get their shoe on. Their feet hurt. Can't wear regular shoes. So if it's still wide from that point to that point, what did we really do? Maybe a little bit of cosmetics. So this is my case. This was 2011 when she walked in the door, and this was like a few weeks ago. She's like, my bunion's back. I'm like, yeah, that was a long time ago. I did that head procedure. The thing is, when I put those screws in, way back in 2011, they were straight up and down. Now they've rolled back to where we were. We're still unstable here. In fact, I went back and looked at my x-rays. That's what she looked like in the operating room. I think that sesamoid's good. Toes straight. I think this is either 3 or 6 weeks out. We're still pretty good. It won't last. It can't. The mechanics are off. So I'll probably come back to her and do Lapiplasty. And honestly, these are a little bit fun to watch. If I leave those screws there, do all my work here, under live radiographs, I turn the positioner and then I watch the screws rotate. I know the whole frontal plane is happening. So that's a before and after. So my goals are, 1 is parallel to 2. You can't see the joint because it's fused. I have these plates on that are at least 90 degrees to each other. Bump is maybe shaved, I don't even know. It might be just rolled. But sesamoids, everything, the construct is straight. It's not pronating anymore. Occasionally, when I'm in there, under live fluoroscopy, I squeeze that right here. If this whole construct moves over, now I know it can move from here. So I throw another screw across there, just to stabilize that. So Therese says, let's address these challenges. We should be doing this, but nobody wants to do it. So John Therese, the founder of the company, he did the same thing with kyphoplasty. I believe that's Medtronic's. Kind of said, nobody wants to do this. Kyphoplasty is a made-up name. They made it up. Like, nobody did that before. So they just named the procedure after what they thought they could do, and it come a long way. So they made up the name Lapiplasty, too. And so now there's all kinds of them out there. Lapifuse, whatever. They stick Lappy on there. So Dr. Dayton is the one I talked to that was giving that lecture and talked about the rotation of that metatarsal. And he's talked about it so many times, like he hated post-op day. Why should me as a surgeon shouldn't hate post-op day? I should love what I see. And it's always this, is it going to fall apart? It's a bad feeling. And if 50% of your people are falling apart, it's not a good day. So they created these cut guides, instruments, stepwise training. We do it the same way every time, same criteria. Get that sesamoid axial on every single one. Make sure they don't have arthritis because that will prevent the reduction. The next thing was AO is, I believe, a German word. Arbeitsgemeinschaft for Osteosynthesis-Fragen, something like that. A bunch of Swiss orthopedic surgeons in the 70s said, let's come up with the defined principles of orthopedic surgery. And here's what they are. And one of them was rigid internal fixation for fractures or fusions. As rigid as you can get it. Push those bones together. Do not allow any bone callus formation. And that is called primary bone healing. Secondary bone healing is when you break your metatarsal, you don't have surgery, you develop a bone callus, right? You kind of get this lump. We always say it looks like cotton candy. It makes a scaffolding of loose woven bone, and then it bridges tight bone across, and then it gets rid of the scaffolding. That's called secondary. In all of my training, I always thought that was backwards. It was almost like we're saying, Mother Nature, we know better than you that the better way to heal is this rigid fixation. So fast forward another 30, 40 years, and AO says, well, maybe we were wrong. Maybe Mother Nature really had this right. Maybe we need a little micromotion to actually get us to heal. So we changed to these plates that have an arc to them and are flexible. And we just made them 90 degrees to each other so they can't rotate. If you just had one plate, it could rotate. And we walk them early. So that relative stability is replacing what we used to say is rigid internal fixation, non-weight bearing. So this is, and I put current because Tricia knows I change it probably every day. Some of the Lapiplasty originals will leave the OR with just a light dressing on there and tell the patient, don't walk. Here's your crutches. Come back in 7 to 10 days, and we'll put you in a boot and walk you. I started with, oh no, this is a fusion. They're getting like a cast or a splint all the way up to their knee. Well, that kind of defeated the purpose of the whole, and it's all over the internet saying no cast. I'm like, well, shoot, yeah, it says no cast, but not for me. So I went back and I'm now doing what's called a slipper cast, and I honestly couldn't find a really good picture. My slipper cast is dressing that's mostly forefoot, a little loop around the ankle. I take a roll of like 3-inch plaster and go once, twice, around the heel, and once more. That's it. And then the H-wrap goes over the top of that. So it's the little bit of that it's holding it, and a little bit of a reminder to the patient, don't jump out of bed and step on this. So they wear that for 2 weeks. And they have crutches, scooters, something to stay off of it. I tell them they can use their heel to pivot. They can use the heel to go up the stairs, but I tell them, not step over step. Your good foot comes on your heel. And then at 2-week mark, they'll come back in. I would like to be 10 to 14 days, but my surgery days are Thursday, and it always seems to end up that it's almost close to 2 weeks anyway. I just need that amount of time to get the stitches out. So surgery day, 10 to 14 days later, they come back. I take that little slipper cast off. I remove sutures. X-rays are taken. If everything looks good, then I put them in a walking boot. So they can get it wet. They can walk in that boot. They don't need the crutches. Some people do. Some people still want to use that scooter. But I'm more encouraging them, put weight on that. We want that micro motion. Your body has to sense there's motion across a joint that needs to grow bone, and it'll start growing that bone. And then they come back 4 weeks later, which is the 6-week post-op. At 6 weeks, I take another full weight bearing. A lot of people at that first 2 weeks are hesitant to put that foot down. I want to see where the whole metatarsal parabola lands at the 6-week mark. And they move from the boot to physical therapy. Now I put formal PT if they haven't already. There's kind of a movement to move to earlier physical therapy. You guys know better than me that we've sat people down for months and months and months. I didn't work on their ankle, but I immobilized their ankle, and now we have an ankle problem on top of their bunion problem. So if I can encourage them at the 2-week mark to do non-weight bearing range of motion, to keep their tendons moving, their ankle joint moving, not necessarily any bands or belts or anything to move the forefoot, but just doing it. And so sometimes it's even better if I can figure out the right patients to send them to therapy early. Come over at 3 weeks and you guys go through non-weight bearing with them. Then by 6 weeks, they're ready to go to weight bearing, and they're going to try to transition to their athletic shoe. Always, 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 I tell them to buy a bigger shoe. And they'll come back in and they'll say, I can't fit my old shoes. Yep, it's going to swell. Probably the biggest downside of this is that because those plates are moving, your body recognizes instability, and what does it do? It swells. I explain swelling to my patients as your body's way of splinting. Before we had plaster and fiberglass, how did we heal bones? We were swollen, which is stabilizing. We had pain, so we didn't walk. So we're trying to minimize their swelling and their pain. A lot of times we'll get them into compression sock at this phase as well. And then between 12 and 16 weeks, 3 to 4 months, we assume they can go back to regular running, jumping kind of stuff. If they really want to get into these, it might not be for 6 months to a year. It was one of my old bunion surgeries, but it was a friend of mine, and I did her surgery in January. And May was her daughter's wedding. She's mother of the bride, and she's wearing heels and turns to me and says, "I got to come and see you. Look at my foot. I must have done something to it." I said, "No, you had bunion surgery." "Oh, that was so long ago." "Yeah, but you're wearing these heels, and you've been up all week." And the next New Year's Eve, I saw her again. I said, "How's that bunion?" "Oh, I've forgotten about that." Because the healing process, they're asleep on the table. They don't know what I did in there. They don't understand the healing process. So sometimes that's the education point. I tell them right up front, just plan on buying a good athletic shoe in a size bigger. They'll want to go get the sloppy Kmart special kind of thing, and don't do it. You just spent all this time, took all this risk, buy a good shoe. What else is new? I don't know if you've seen any of this, but this is minimal incision surgery, which is also highly marketed now. On the outside, it's a poke hole here and a poke hole there. I don't do this because the mechanics don't seem correct to me. And they love this. This lateral cortex is up against the medial cortex, and that is their goal. Don't know really how I'm going to fix these when they come back in and see me. I've seen other people have to fix them. And, they advocate early walking. I'm not quite sure who's pushing this. Patients want a smaller incision, and I try to educate them that if I do this incision right, we keep the swelling down, in 6 months' time, you will not see that incision line. And I'd rather have the access to the joint to do it correctly than just make a pretty thing on the outside, and then the inside is this. So people will say, "Do you do minimal incision?" Or I think maybe even in some of the marketing brochures for Lapiplasty, they'll say minimally invasive big toe joint. What they were trying to move toward was, I'm not disrupting the capsule around this joint. I'm doing it all back here. And then when it's physical therapy time and you guys are trying to move it, it can move. Because we haven't done anything to create scar here. This motion of this joint is very minimal compared to your joint here. When I try to isolate that first metatarsal cuneiform joint, a couple millimeters up and down and very little rotation. You can't get your big toe to push off. You're doing this, right? So that's kind of why Lapiplasty, why you're seeing it so much. It was a big marketing push, but it really, really made sense to me. And then I've done many of the trainings. Maybe I'm at 150, 200 now. I started in 19. We were going pretty strong, and then COVID hit, no elective surgery, and then now back to it again. I still have people come in probably every day I have clinic that say, "I've seen this, I did bunion research, I want to talk about this." So it's out there. I can't say like the other systems, Lapifuse, they all have a name now. I can't say any of them are bad. I really just don't know them. But the big point to me is aligning that in the frontal plane as well as the other two planes. If we don't address that, we can't restore the normal function of the big toe. All right? I did throw in just one more bonus subject because it's football season, and this is common in football, and it's very, very easily missed. So if you're seeing this, your player gets stepped on and comes up over the top. that's where we see it. Their foot is held, their forefoot is held, and they come over the top. They'll look like this, and they'll get diagnosed with a foot sprain because really nothing is showing up on a plain x-ray. If you're out there doing things in the field, you see an athlete come in here, that's a common one in football. But we see them for, I'll show you, these two were this week, not that at all. One actually got hit by a car in a crosswalk. Another one was, who was he? Guy who was in for the MRI of his ankle today.
I know he injured it originally, but
Yeah.
I don't remember his mechanism.
We've seen wearing flip-flops running up the stairs. The flip-flop hits the edge of the step, right, and their forefoot's held, and they go over the top. Lots of them. So what we're looking at here, this is a long ways out for him, a couple years. The base of 2 and the first cuneiform have that gap right there. This is a CT scan. They were showing me the same thing. She actually has a crack of her second metatarsal. She got hit by the car, and there's a gap. So your Lisfranc's ligament is this, the lateral side of C1 to the medial side of M2. That's where it's the strongest. That's your keystone of your arch. That second metatarsal sits the furthest back. If that blows out, the first x-ray, it hasn't done much. As they walk, it's this. So now I'm seeing people that kind of have this twist to their metatarsal because the ligament blew out. Now that I'm looking for that, they don't have a bunion. They have an old injury that just twisted. So anyway, that's why I threw that one in there, because you'll probably start seeing the fall athletes. And that's what I got. You guys have any questions for me?